healing results that he's been able to achieve around implants. His presentation is titled Treatment Results for Peri-Implantitis Using the Nd:YAG Laser. Ladies and gentlemen, Dr. Gary Schwarz.
Thank you. Good afternoon, how's everybody?
Great.
Good. Well, I still hail from Texas, southern Texas. I'm down near the Red River. And everybody thinks I'm being overrun with illegals, and I just hardly ever see it. It's the weirdest thing. But it's good to be here. This is my third year in a row. How many people have heard me before, either at the Seattle Study Club Symposium or here? Okay. You'll probably recognize some of this stuff. There's quite a bit of new stuff as well. But, you know, it's an honor for me to be here because I promise you, the thing that separates me the most from my competition, I'm an oral maxillofacial surgeon, and when I say my competition, I'm talking about oral surgeons, not periodontists. But what separates me and has allowed me to excel is what I learned from y'all. Because I realized a long time ago, for me to be what I needed to be in implant dentistry, I needed to learn how to handle soft tissue like you guys know. And I'm not saying I'm as good as y'all, but I'm a whole lot better than I would have been had I not gotten taught by people like Maurice Salama and people like that. So thank y'all for what you've done to advance the field of implant dentistry. But I want to tell a story about how I ended up here, because I didn't plan it, you know. But I've always loved implant dentistry. We started doing raiment frames and subperiosteal implants when I was a resident. And, you know, the moment you put those in, they start being rejected, right? The concept of osseointegration was nothing I dreamed I would ever see. When Brandemark published his paper in 1983, I was just stunned, you know. And of course, we immediately started doing that. But as the years went by and my implant practice grew, I didn't see peri-implantitis at first. You know, I was really blessed by being able to be chosen one of 5 people to go operate with P.I. Brandemark at Seattle, Washington with Philip Worthington. And of those 4 other men that were with me, all 4 of them have done great things in the field. 2 of the guys that were there were Ole Jensen, the oral surgeon, and Carl Misch, the dentist. And I'm the only one that hadn't done anything. And now here at the end of my career, I come across a technology that to me is as revolutionary and shocking as what titanium was to osseointegration. This is to those osseointegrated implants that get sick and start losing the bone. So I want to share with y'all that story with y'all, and I hope I can motivate some of you to take a serious look at this thing. But it's like pushing against water to get people to realize it and to see it and believe it. And so anyway, that's my task today. Going back to the beginning, to this day, I've never treated one of my original Brandemark implants for peri-implantitis. Never. I think there are 2 reasons why. They were narrower, so you had more bone around them, which makes them more bulletproof, more tissue around them because they're narrower. But that smooth surface, there was something magical about it. The problem was you couldn't load them, and we wanted to do things faster, and so they came along with the rough-coated, root-shaped implants, and you know, I started putting more and more and more and more in, and with that, increased the probabilities of problems. And by the late 2000s, I just started seeing lots and lots of sick implants. And it made me sick because you do this beautiful case, and the dentist, restorative dentist, would do beautiful work. Patient would spend a fortune, and then they come back and they're spitting pus. And it's like, come on, it was just awful. And so I spent 3 years doing everything I knew how to do, and nothing was working. And so, you know, I'm a clinician, I'm not a researcher. But it's easy to review the literature now with Google and all the information that we've got access to. So I reviewed the literature to see what I could find and to learn what I was doing wrong. Now, peri-implant mucositis, I could handle that. You know, typically around an implant that you place, they come back 3 months later and it looks like this. I'd unscrew the abutment, rinse it out with chlorhexidine, put some arrested in, put the heating cap back on, and 99 times out of 100, that's going to take care of that. But this booger is a different animal, peri-implantitis, where it's progressed to loss of bone, That was a different animal. And so, excuse me. So, what did the literature say about what other people's experiences were? Well, the first thing I found was it wasn't just me. It had become an epidemic recognized by researchers by the late 2000s. And one paper said there was an estimated 1 million implants being removed worldwide. Another paper said in Europe, 50% of all implants were sick. 50%. Nobody did a study about like that over here, but it's got to be similar, I would think. So the first really good review paper I found was the paper in 2008 from the Lindy European Conference on peri-implantitis. And they looked at all modes of therapy, and the conclusion was that nothing is working. Nothing, some things work sometimes, but nothing works most of the time. But the one thing I saw here was number 2. And it's the one thing I hadn't tried, which was, it said that some promise exists with laser therapy, but it needs further study. The next really good paper I found was the Ography paper in 2012. It reviewed the literature, and nothing had come along in between 2008 and 2012 to change the conclusions, which was there is no clear choice, and high failure rates continue. The next really good paper was Monty in 2014, and he looked at all the non-surgical approaches. He looked at the surgical approaches, all of them, and he found that at the present time, 2014, treatment of peri-implantitis should be considered possible, but not necessarily predictable. In a recent review paper in 2018 that I didn't get a chance to put up on here, add to it, is we're still there, guys. It's at the same place. So what do? Do you just give up and let people walking around with pus coming out around the implants, and knowing that the medical literature is now showing that sick implants contribute to cardiovascular disease and diabetes and exacerbate those conditions, among others? You got to do something, and yet we just saw nothing's working. So I asked myself, what about this laser thing? I had a terrible opinion of lasers. I mean, most of the guys in my area that were using them, it was a gimmick thing. They would advertise it. And I mean, what can you do with a laser that I can't do with a blade and a cautery faster when it comes to cutting tissue? And on top of that, I don't have to get all those consent forms and get these glasses on everybody and the liability potential issues. Because lasers are very heavily regulated. And so I had no interest in using it for conventional surgery. But I couldn't make my blade or cautery stop peri-implantitis, and neither has anyone else. So I checked with one of my dentist buddies who I knew was using a diode laser. I didn't know about the different kinds, and so I bought one and started using it. And I would do the flap, and then I would use the diode to help clean things around the implant. And I didn't get great results, but I saw better results. And so I presented this lit review and my experience to my Seattle Study Club. And as I'm walking out of there, a dentist who I had a lot of confidence in, he said, "Gary, listen, dude, you're using a pop gun." And he said, "It's non-selective. You need to go get the Millennium laser." I said, "The what?" He said, LAPIP. Now, I'd never heard of any of those things. But I was intrigued, and so we called and got a hold of the rep who was in my office the next week. And he showed me the Nevins paper on using this laser to grow bone back around the roots of teeth that had perio. He showed me the Ray Yuckna paper, and he showed me a handful of implants with bone growing back. I couldn't believe it. I couldn't believe it. I'd never in my life seen it. Now, I don't know if you guys can grow bone with a blade. I'm sure some of you can, but no periodontist in my area have ever been able to do that. And I was sold, man. I said, I want it. And he said, "Well, you can't have it until you pass boot camp." And well, that impressed me even more. It really did. And so I gave him a $5,000 down payment or whatever it was, and I started going through boot camp. When I got my manuals that I had to read and study and prepare for, I couldn't believe it. It's like I'm back in the residency. And so I go up there, and I get trained, and I was so impressed with all that. And so I came back and I started doing implants, treating sick implants. Now guys, before I go any further, I want to stop right here and I want to tell you something. This is coming from the bottom of my heart. I don't have one bone to pick in this fight over what works and what doesn't work. Because I have no financial interest in this company, and what Dr. Greg pays me to come do this, it doesn't even touch losing 2 days of work. If I'd have been home yesterday and today working, I'd be miles ahead financially of where I am now, believe me. I'm here because I believe in giving back to the profession that's been so good to me. For years, I just practiced my practice and concentrated on my clinical relationship with my patients and my dentist to grow a great practice and to support my passion, which is ranching and enhancing wildlife. And poured all that money into that. And I just didn't have time to give back to my profession. But when this happened by accident and I began to see the results of the work on my implants, I said to myself, I got to tell this story. I got to tell this story. But I did a thesis, but I don't know how to write a paper now. I don't know how to do the statistical breakdown of all this. And so I hired a man, David Harris, who has written more research papers on lasers in dentistry than anyone else. He's done most of the research analysis for a millennium. And so we began compiling data. But before I get to that, let me just quickly run through with you how this works. And this is what I learned at training. Of course, the patient gets in the chair, they're sedated. You've already probed them ahead of time. But now they're anesthetized, and so you probe all the way to the bottom of the pocket to determine how far down this probe has got to go. And then this glass probe that carries the light to its delivery point, and you've got to make sure it's as long as what the deepest pocket is. And then so you come in and you do just like you probe in the tooth, but you go up and down and you go all the way around the tooth every 1.5 millimeters or so. So like say 16 points, you'd be circling this tooth, delivering the energy to these pockets. Now this is set on what's called an ablation setting, which is a higher energy, and it just nukes the bugs. It breaks up the mucopolysaccharide smear layer on the implant, and it helps break up the implant to help, the cement, if there's any in there, to help you get that out. The next step is that, and my hygienist now, I'll let her come do this. She'll do the next step is piezo ultrasonic scaling. That's what you see in number 3. And I have her do that because there's not a flap yet. And in Texas, the hygienist can't do this if there's a flap. But they can if there's not a flap. And I hired a hygienist to help me with the documentation for the research paper because I didn't want to do the probing. So initially I did this myself. But then once I hired a hygienist, I had her take that part over. And her job is to get that cement out of there and wash out all the debris. Step 4, I come back in. This is the last tip that's used on the piezo. It's real sharp and real thin. And you go all the way to the bone and aggressively scrape the bone, because what you're doing is 2 things. You're really stimulating a lot of bleeding, because the last thing we're going to do in number 5 is we're going to stabilize that blood clot on a setting called hemostasis setting. And it really works, isn't it? Because you want to fill that space that was a pocket with blood. The second thing that scraping does, it releases growth factors. And so step 6, you compress with your thumb and your forefinger the tissue and the clot back up against the implant. And then the very last thing to do, step 8, is an aggressive occlusal equilibration. And what you're doing is you want to get the forces forward onto the canines and off of that implant, or have very, very light contacts on that implant. And you've got to be obsessive compulsive about this, because it's not going to work if they've got traumatic occlusion on it. And I'm even so aggressive that if I've got an open bite that's not too severe, prior to that appointment, I'll have the dentist bond to the lingual of the upper cuspids to create contact where they don't have it naturally. And then, of course, the bite splint is important as well, but they can't wear that 24/7. So working with the natural teeth is really important. If the open bite is too severe, then I'll get everything in group function in the back and then take the implant out of occlusion and shift the forces onto the other teeth. So we began compiling data. The protocol for determining who I was going to treat, I just followed what the literature said. The literature defines peri-implantitis as any pocket that's 5 millimeters or deeper, whether it bleeds or not, and any pocket at 4 millimeters that bleeds or has pus. So those are the patients that we treated. A paper, the only paper that is in the literature now that I know of on using the Nd:YAG laser to treat peri-implantitis is Dr. Dawn Gregg's paper that she published in 2014. They took 16 LAPIP clinicians who had been trained and certified that had treated peri-implantitis cases and had them send their single best case. So these are one case from 16 different guys, and it was a super, really a good paper. Now you notice down here at the bottom, at that time, they were worried about the energy, delivering the same energy around an implant that they had found worked around the tooth the best, because they were worried about liability, they were worried about hurting people. We were in a learning stage. They were worried about that implant radiating and causing tissue damage. And so they initially recommended 1/3 the energy that you see down here at the bottom that you do on a tooth. And so when I came back and I started doing that, I just wasn't getting good results. But I got a lot of sick implants treated, so I just gradually started increasing. And what I found was when I got up to about the same thing we were doing around a tooth, I started having success. You got to kill the bugs. 1/3 energy wasn't killing the bugs. My average dose on my first pass on ablation setting is it comes out to between 150 and 250 joules of energy. My second pass, when I'm stabilizing that blood clot, I'm coming out between 75 and 150 joules of energy then. If you go get trained by Millennium, they have a new formula they've worked out where you take the total millimeters of pocket depth and multiply it by a number to come out with how many joules you need to do. And that's what you should do when you start out. But as your experience grows, you will find, I mean, the ones that have the deeper pockets are going to take more time. Ones that have a bulkier crown form are going to take more time. I don't have the dentist remove the crown every time. If I have failure on that first treatment, then I do. If they're cemented on, I'll have the dentist do an endo prep down to the screw and unscrew the abutment with the crown cemented to it, converting it into a screw retained crown. And my second treatment will be done without a crown. So David Harris came into my practice, and he had my hygienist start compiling these data sheets. So I have, for every patient, for every implant, there's one sheet where we record progressive over time, the pocket depths, whether there's bleeding, whether there's pus, whether there's redness, and whatnot. And my hygienist does all the probing. Like I say, I don't do any of it because I want to separate me, the researcher, from the data collection. And I don't even look at what's happening with these books. Whatever was going to happen was going to be a surprise to me. David Harris analyzed the numbers, the hygienist compiled the numbers. Here's what we found. From October 2013 to September 2016, I treated 222 patients with a total of 437 implants. The mean age was 65.8. We documented 7 medical conditions we thought might have a role to play. We wanted to track that. We looked at probing depths, redness, and purulence, pus. The summary, 222 patients with 437 implants. Of those patients, I only had 116 with 224 implants that had complete data. Why is that? Because I didn't start out to do this. It took me about 2 years to decide to do this, 1.5 years anyway. And so a lot of my patients, we had probed them to determine that we needed to do it, but not being a periodontist, my staff didn't write the numbers down on the pre-implantitis study idea. Before I got that idea, we had inconsistent reported probing depths. So we couldn't include them. Everybody who had complete data, we included them. The reduction in probing depths was significant to a p-value less than 0.001. Efficacy, which is the elimination of bleeding on probing, redness, and pus. Improved at first follow-up in 103 out of 116. Now it says implants. Now I had to call my researcher yesterday and tell him this doesn't make any sense. And so here's what the statistician has to do. And I don't know why this is, but this is what he told me. We have 116 patients. You see that? The second mark. 116 patients. There's 224 implants in those mouths of 116 people. But to do the statistical analysis, to eliminate bias, he picked the one worst implant in each of those 116 patients to enter into the data, the sickest implant. So that's why there's 116 implants that he does this efficacy analysis on. So elimination of bleeding, pus, and redness took place in 89% of the patients. All decreases in secondary outcome measures were significant to a p-value of less than 0.001. 16 of the implants were lost or removed, that's 6%. And there were some medical conditions and other issues that looked like they may have played a role. I then thought, man, we're on a roll, this is so cool. There's nothing in the literature like this, nothing. So I'm thinking, Journal of Oral and Maxillofacial Surgery is going to publish this is going to be cool. I'm going to be proud of having given back. We send it to Journal of Oral and Maxillofacial Surgery, and they held it for like 4 months, and they sent it back. And they didn't even suggest anything we could do to make it better for them. They sent it back and say, single investigator retrospective study with success rates too high to be believable. We don't want it. So then we sent it to the International Perio Journal. Same thing happened, held it about 4 months, then sent it back with similar comments. Then we sent it to 3 other dental journals. We sent it to 5 dental journals, and the same thing happened. So David and I are getting kind of frustrated. We're in a rush to get it into literature, and so David says, let's send it to photomedicine and laser surgery. And man, they loved it. They loved it so much they were going to make it a cover story on their December issue. And then Bob Gregg, the owner of Millennium, called me on the phone when he found out where we had sent it to for our 6th try. And he said, Gary, I'm not going to tell you you can't do it, but I'm going to beg you not to. Because we have learned through the years that when you publish something in one of these laser journals, very few people find out about it. And he said, I'm convinced we can get it. It may not be an elite premium dental journal, but we can get it somewhere, and I'd rather have it in a lower quality dental journal than a peer-reviewed premium laser journal. And I wasn't happy about it, but I agreed to do it, and you know, he's got great experience. But I'll tell you guys, it has been frustrating. You know, it makes you want to just forget all this research stuff, but I can't because I believe in it, and I believe in him, and that's why I'm here, even though it doesn't make financial sense for me to be here. So anyway, we'll see what happens from here. David, about the time we pulled it out of that journal, I got David off. I didn't want to come here and just talk to you about old information, because meanwhile, we've been compiling more information as time has moved on. So I got the information on more patients through July of 2018 and got him that data. And here's the new numbers. We now have, remember we had 116 patients with good follow-up data out of the 222. Now we got 155 because some of the patients that had been lost to follow-up came back. Now we got 155 patients with 299 implants. 1 additional implant was lost. Mean follow-up is now 24 months with a range of 1 to 63. 68% remain successful in terms of no redness, no pus, no pockets, no bleeding. One just totally well. But we've kind of changed what we're calling success. Remember we said we had 89% success before? In that 89%, there were some patients that still had just a tad of bleeding, you know? You probe something, you can take healthy tissue. If you push hard enough, you can make anybody bleed, right? So there's a little bit of a judgment call sometimes. And also in there were patients who had 9mm pockets 6 months prior to the probing of the follow-up. Well, you're not going to grow bone back from 9mm in 6 months. It takes 2 years. And so we called those a success too. But the interesting thing we found, you see here, the 11% relapse. 11% of the 89% success rate relapsed at 24 months. But the interesting thing was that most of the people in the relapse group came from ones that we had called successful, but had those little issues. Just a tad of bleeding, and the pocket is shrinking, but it's not back to 3. And so we decided, you know, we've got to look more critically and call and create another group called partial responders. These are patients that get better, but they're not 100% there yet. So now we're looking at that. 5% have failed in all. This is still far and away 1,000,000 times ahead of anything else that's being done. And so hopefully we can get that other one published, the old one, and then we can get more information in the next year and then publish this. Here's a pie chart that helps you see it. Of the current 68% that are really doing well, we've got long-term data on 48% of them, and short-term data less than 12 months on 20% of them. Then you see the 11% relapse and the 16% that are doing better, but they're not out of the woods yet, and then the 5% that fail. Just showing you now a few cases. Here's an example of a long-term success. This is a 2 lower implant, overdenture with locators. One implant on one side was super sick. The other one on the other side was just fine. And you can see how deep those pockets go. And at 6 months, this is an example of what I'm talking to you about. We called him a success at 6 months, but you can see he's still got bone loss. He hadn't filled in completely. But look at him at 30 months. Well, these people, even though we called him at 6 months a success, other patients like him have subsequently relapsed. Just a diagram of the bone growing back, how you see it over time. Here, the X-rays don't really show you much. You know, a lot of times there's deep pockets, but because it may be more on the buccal, where you're not going to see that on a PA X-ray, you're not going to see buccal bone loss or palatal bone loss. You'll only see it if it's interproximal. But look what happens. And we start out, we've got redness and bleeding in 4mm pockets. They come back at 6 months, and we still have the 4mm pockets. They're just not bleeding, and they're not red. And then look at 12 months. They're shrinking even more. And look at 24 months. We got 3, 2, and 2, and no signs. And then 36 months. Look at this. Look at this relapse. It relapses at 3 years, and now we've got 6, 6, and 5 on the buccal. And again, that's why we don't see it on the X-ray, because that's where the bone loss is. Here's an example of a failure case. We treat him over here at 2015. 19 months later, he's worsened considerably. 30 months later, I mean, it's about to fall out. He was treated 3 times. One of the things we found, what we found out of that 89% was that 79% responded following the first treatment. 21% did not. We treated them a second time. 50% of the failures the first time responded the second time. So now that 21, we get 10 more from that. That gets us to the 89. And then 11% that did not respond to treatment, they're now in our group of partial responders, because they all partially respond. Nobody has a no response. When you treat them, kills the bugs, their inflammation, their redness, their bleeding goes away. I see them the next week, they look unbelievably better. And then I see them at 2 months, they still look better. I see them at 6 months, 11% have gone south. Here's an example of a partial response. Over here on 2014, you see 9, 9, and 9 on the buccal, 9, 9, and 9 on the palatal. We treat them. They come back. They still have the deep pockets, still have some pus. Treat them a second time, and at 15 months, it goes away. The problem goes away. And at 33 months, we get a relapse. with once again bleeding and once again deepening of pockets. So, you know, they're just like perio patients where I suspect y'all see a very similar thing. Does seem to be a connection to a number of things. Number one, systemic illnesses, uncontrolled diabetes, older age, thin scallop tissue biotypes, limited amounts of bone, implant walls close to the buccal plate. We're beginning to see a trend in those things. Here is an example from the Nicholson paper of those 16 cases she published. Back that up. This graph is really cool. Over here shows when the patient was fine, and then over time they began losing bone, and then to the point that LAPIP was done. And then after LAPIP was done, you can see the time it took for the bone to grow back. These just more radiographs of some of our cases. I want to get on and show you some other cool things. So LAPIP's done in my practice per year. 15 in 2013, that's because I got trained, I got my machine in November. So I didn't have many months to use it. And then the next year, 2014, 135, 2015, 159, and look at 2016, 305. What's happening? What's happening was, I mean, those patients were all there. Some of them got sick, you know, in the interim period of time, but most of them had the peri-implantitis, but dentists weren't probing. So when I got back from training, I had meetings with the dentist and with hygienists and said, guys, you got to start probing these implants. You got to get them to me before they got 9mm pockets. I want to see them at 4s and 5s or 6s at the worst, and you're not going to know it if you don't probe. And so they started doing it, they started seeing the results, and they got really motivated and excited about it. So then why did this happen in 2017 where it fell to 125? What do y'all think happened? It's working. It's working. Now that includes my retreatments of the relapsed ones and the ones that the first treatment didn't work. And that also includes the other oral surgeons starting to send me implants of their own that were sick. And then it jumped back up to 180. But that's partly the relapses, partly the growing implant practice that I have. So that's pretty cool. 919 total LAPIPs that I've done since 2013. Here is a chart to show you the income I've generated with this machine over the last 3 years. One of the things that drives me crazy is, you know, my daddy told me a long time ago, he said, son, you need to be honest, you need to be confident, but humble, and you need to always do it the best way you possibly can, and don't go the cheap route or the short route just because you think you have to. He said, because most of the time you'll end up regretting doing it. Now, if you're doing implants, you're going to have sick ones because you're no better than all the other guys in the world. I mean, you're better than a lot of them. But everybody's having implants. Sick implants. It's an epidemic. So you're going to get it. Well, what are you going to do? Are you going to ignore it or are you going to treat it? If you're going to treat it, what are you going to treat it with? I showed you the literature on everything else. So what's left? What's left is the Nd:YAG laser. Now, if you're going to do the Nd:YAG laser, you got two choices. You can buy the one that has the research and data and incredible training, or you can spend half or less and get the photon that has a bonus. It has an erbium laser in it too, so you can cut tissue. It'll cut tissue really good. But I don't want to cut soft tissue with an erbium. I want to use my knife and my cauter. And so, how do I, and that machine is not going to cure peri-implantitis, even though it has an Nd:YAG laser. How do I know that? Two reasons. Number one, its laser is not putting out the energies this is. You know, all automobiles are not made the same. And I have personal experience of two people very close to me who went against my advice. It upset me so much. A dear friend of mine from oral surgery times, he practices in Fort Worth. He's an awesome oral surgeon and a brilliant guy. And his guy that does his all-in-4 conversions is the same one that does mine. And Daryl flies, I fly him down from Dallas to do the conversions with me and my dentist. And Daryl saw a really sick all-in-4 conventional case and a really sick all-in-4 zygomaticus case. And the zygoma case got infected on the zygoma where the implant had just barely protruded through the outer cortex of the zygoma. And they were from Mexico, went to a surgeon who thought it was a tumor and cut them open and saw that little metal gray tip of the zygoma implant. And so they came back to me, I told them what I needed to do, which was make an incision and use the laser to treat the tip of the implant. And do the same thing, but on the other end. And so they went back to their dentist, they were very upset, they wanted a second opinion, so Roy called me and said, who do I send them to? And I said, send them to Dr. Stella, who runs the program, John Peter Smith, John Stella, brilliant guy. Go to John, and John says, all we can do is take it out, start over. So they didn't like that, so they came back to me, I treated them, I got it well. That was 3 years ago, and it's still perfectly fine. But one of John Stella's past partners was Greg Schottenman. And Greg is the one that my guy said, call Greg and tell him he's got to get this machine. So I called Greg on the phone. I said, dude, you got to do this. And so Greg wanted to, but he had two partners. And these two partners heard the rep from Photonis say, it's the same machine. Half as expensive, and you don't have to go through all those days of training. So they bought it. Meanwhile, my daughter, who was my first hygienist, moved to Fort Worth with my son-in-law to go to seminary, and her dentist, she got a job with, is a big implant dentist, and she calls me on the phone and she says, Dad, I told him about Millennium and he met with the rep, but he can buy this other one so much cheaper, and it's the same machine. I said, Caroline, it's not. So what do you think happened? Neither one of them had a bit of luck treating peri-implantitis. Both of them tried to get their money back. Neither one of them was able to. The dentist is parked in the closet. He doesn't even use it. The surgeon uses the erbium laser to cut soft tissue away. Just quit trying to treat peri-implantitis. So I plead with you, pay attention to these numbers. Oh, so look, Lynette, I get back, besides teaching them to probe implants, I told them about what it would do with periodontal disease. Now, I don't want to treat periodontal disease, but you can't ignore this, and meanwhile, I'm trying to get other people to get trained and do it themselves. And so that first year, I generated whatever it is, I can't see it from here, 68,000 from Lynette. The next year, 32,000, the next year, 20. I'm going backwards with Lynette, right? That's what I want to do. I'm an oral surgeon. My best referral guys the first year saw what happened. They went and got trained and bought their machine, started doing it themselves. Okay? Meanwhile, look at LAPIP. 186,000 3 years ago. I didn't go back 5 years because the first 2 years, the first year was practically nothing. The second year was less than this. But 76,000 in year 2, and then 2 years ago, and then last year we saw it jump back up to 95,000. So I bought this machine for a LAPIP. That's why I bought it. And it's paid for itself many times over, not counting what it's done for me and my stress. But look at this other thing here. Biostimulation. 3 years ago, $4,100. Before that, it was $0. When I heard about biostimulation at my training, I thought it was kung fu stuff. I mean, I thought it was like a magician waving a wand or something. It made no sense to me. I did not see any science behind it, and I wasn't going to come back and do that. They said it works. We see it in the tissue, but I'm not that gullible. I got to see evidence. I saw evidence on Lynette. I saw evidence on the LAPIP. I needed to see evidence on biostimulation. In 2014, I got it. Read a paper out of South Korea where they studied the effect on osteoblasts, and they found out that the Nd:YAG laser penetrates through, hits the mitochondria on the osteoblast, and turns them into overdrive, and rapidly accelerates bone formation. Well, that was enough for me. So I got my treatment coordinators, we started recommending it, $4,100 3 years ago, $68 2 years ago, and then $64,000 the next year. Went down a little bit. So what happened there? What I started doing was a procedure I called decon biostim. Decon is decontamination. And where I use this is when I take a tooth out, I'm going to recommend to that patient most of the time either an implant or a socket graft. Not all the time, but most of the time. And so whether it's the implant or the socket graft, that bone or implant is going to be going into a contaminated socket. There's bugs there, pathogens. And so the same way this laser kills pathogens in the periodontal pocket, it'll kill the pathogens in the socket. So I do the decontamination first, then place my implant or my bone, and then my hygienist in Texas is trained to use the laser and can use it in low energy settings, which biostimulation is. So she comes in and does the biostimulation. And guys, we started at first doing this on one side of the mouth and not the other, and the difference is amazing. I mean, on the biostimulated side, you look at them at 2 weeks, and you have pink, matured gingiva covering the socket. It's unbelievable. The other side, it's red and just started. Incredible difference. So look at decon biostim, what it's generated. When we first started 3 years ago, 32,000. Last year, 179. This year, 201. It's unreal. So the literature behind it is pretty incredible. I'll show you that in a minute. Total production with the Millennium laser in the last 3 years. You see the numbers there. So spend, you know, between your training, I don't know what they charge for the machine now, but you're going to probably spend close to $150,000 between the machine and the training. Can you pay for it? I think so. It's the most profitable tool in my office. I mean, once you get it paid for, there's no overhead other than sending it in once a year for maintenance and then buying your fibers, which isn't that bad at all. Here's just a few. I'm not going to go through these a lot with you at all because you can Google them yourself. Just Google effects of the Nd:YAG laser on accelerating healing, and your phone will fill up with references. Most of them are from Asia, but here you go, the effect on osteoblast by inducing BMP2. Conclusions, present in vitro findings demonstrate that high power, low level Nd:YAG laser increased osteoblast activity, very efficiently accelerating mineral deposition. Osteoinductive effect of laser is likely mediated by activation of BMP2. Here's another one, found the same thing, looking at filling in of calvarial defects. Here's a great one on the effect on fibroblasts. Found out it just fired them up as well. That's what I'm seeing when I see in the gingiva. Look at this one, accelerating the differentiation of osteoblast to osteocytes sites on smooth and rough titanium surfaces. And just more, here they found an insulin-like growth factor effect. So summary, the impact on my practice. Is the first protocol with a high probability of success to treat peri-implantitis. It doesn't involve a long, expensive, or painful surgery, minimum negative sequelae. You need to tell patients that this laser beam is selective at targeting primarily the bad guys. Its level of, its safety net is 2.5. In other words, what the energy is required to kill the bugs, the bad stuff, is 2.5 times less than the energy required to kill normal tissue. That's a therapeutic index ratio. You know what it is with a diode? It's like 0.5. And so that's the danger of using a diode. It's not selective. This laser's like, if we had a ray gun we could shoot at humanity, it would wipe out the bad people and leave the good people, which is what God's going to do someday. But we don't have that yet, and we're not God. But we got this, and you can use that in the mouth. That's pretty cool. It's hope for me, hope for the patient, less stress for everybody, major practice growth for me, and the bonus surprise I didn't even go for and I didn't even believe in. Decombustion. Unbelievable. What do we need to do still in the future? Better duplication of radiographs to prove bone growth. I'm now doing cone beam before and after on all the patients. longer term follow-ups to determine reinfection rate and find what patterns we can there. And learning what's causing the pocket to shrink. Is it bone or is it just a tight attachment for your bugs? I think what we're gonna find with cone beam is once that labial plate's gone, it's gonna stay gone. Because there's no scaffolding there to guide the growing back of that bone. Even if you get a clot in there, there's no bone around it to help fill it in. And I think what we're gonna find is that tissue, soft tissue, just sticks tight against the titanium without there being bone there. But that's okay. If it's osseointegrated, if it'll hold the tooth, and if the bugs come back, we're still free of disease. I told you I had other passions that preoccupied me from doing this kind of thing earlier in my life. First, it was growing giant deer, and I did it so well, we got a TV show, and Jeff Foxworthy was my partner. It became the most highly rated whitetail deer hunting show on TV. It's called Bucks of Tecumseh. It's still on the air. But my passion now has shifted more towards growing these big bass. And I love digging lakes. It's like sculpture with water. And designing them for these fish. These three smaller ponds you see are forage ponds. So I pump from the Rio Grande River into there, and I stock them with forage. And then as the forage grows so well because nothing can eat it because there's no predators there, I then open these big valves and the water runs into the lake below where the big fish are. And it's kind of caught the attention of the press. I'll show you that in a minute. Here's my family. This was, 6, 7 years ago after a federal trial. The federal government, when we got into a budget problem, the politicians, rather than taking responsibility, wanted to blame it on us, that we were frauds. So they developed this software to find out the biggest producers in all the fields of dentistry. And I was the biggest producer of third molars in the U.S. by a mile. And so they indicted, and the closing argument of the prosecutor, she showed a videotape of me taking wisdom teeth out. And I mean, if you want to put one on YouTube of me, that would be the one. I mean, it would make me really proud. So I did everything right, except I did it too fast. And so when she got done, she turned it off and she turned to the jury and she said, "Ladies and gentlemen of the jury, you just saw Dr. Schwartz take out 4 wisdom teeth impacted from start to finish in 3.5 minutes. And for that, the government paid him $1,300. And that day, he did 42 patients." And my attorney turned to the jury and she said, "Dr. Schwartz didn't determine that fee. He didn't determine that code. He just determined how he was going to take care of that patient. And you saw how he handled it. Now, would you want your son to see Dr. Schwartz or a guy that takes an hour?" And the jury, an all Hispanic, low-income jury, found me innocent of all charges. But it was stressful. And you can see here, I'm a little rather rotund. I weighed about 248 pounds there. That's my wife, my 3 kids, my son, 2 daughters, and their spouses, all the grandkids, 6 grandkids. We love being at the ranch and enjoying that. But I got myself in shape, and last fall at this time, I went to Utah, St. George, Utah, and I got the silver medal in the long jump. The guy that beat me on the last jump by about 1/2 inch. And the guy that was the bronze winner was mad and he wouldn't come take the picture. But I was pretty happy. That was pretty cool. But, you know, at times I feel like I'm just wasting my time. Now, one of the things, and that's what I felt like when I was driving through this water. I kind of got mad at all those editors, and I got mad at people not believing, you know, and I got mad at that water. And we're doing an ad for Polaris. This is their new Polaris 1000 machine. It is a rocket ship. And I told my son, he's filming, but Blair's going, "Dad, don't do it, don't do it." Now, you may not look like it, but I'm doing about 50 miles an hour. You'll see that here in a second. But when the water's parked, it's still there. And anyway, guys, I've enjoyed it. Thank you for having me. I'll be around for questions if anybody has questions. Thank you so much.